Go ahead. Good morning and welcome to the press conference for the 54th meeting of the Society of Thoracic Surgeons. I'm Robin Cohen, Chair of the Workforce for Media Relations and Communication. This morning we have three very interesting articles, two of which document the superiority of surgical therapy over alternative or medical types of therapy, and I think that there weren't further discussion. Our first paper this morning is entitled Durability of Open Heart Surgery Offers Younger Patients Superior Long-Term Results, and it's going to be presented by Dr. Wael Awad from St. Bartholomew's Hospital in London.
Good morning, ladies and gentlemen. I would like to thank the organizers, Dr. Cohen, Mrs. Bagley, for the invitation and the privilege of sharing our findings with you on a topic which I feel is very important, which is revascularization in young patients. I'm presenting this on behalf of my colleagues at St. Bartholomew's Hospital. Coronary artery bypass grafting and stenting are both well-established treatments in patients with coronary artery disease. Both methods of revascularization have been extensively studied and compared in many randomized trials and meta-analyses. On the whole, these seem to show no difference in mortality, incidence of stroke, or myocardial infarction between the two revascularization strategies. However, MACE is often associated with, MACE is often greater in patients undergoing percutaneous coronary intervention, and this is thought to be related to the increased rate of revascularization. However, a lot of these studies were undertaken in low-risk patients, patients with 1 or 2 vessel disease, normal left ventricular function, and we know that the prognostic benefits of coronary artery bypass surgery is greatest the higher the risk of the patient. Thus, these trials are inherently biased against the prognostic benefit of surgery. Advances in percutaneous coronary intervention and stents have led to an increasing use of this procedure in patients with 3 vessel disease and left main stem. The absence of studies specifically comparing the outcomes of these two revascularization strategies, specifically in young patients, has resulted in this group of patients being primarily offered stenting with a view to deferring surgery. However, we feel that the morbidity and mortalities associated with coronary artery bypass surgery in this group of patients would be small, and we question the appropriateness of this strategy. The aims of this study were to examine our procedure risk and to compare the mid and long-term outcomes of young patients undergoing coronary artery bypass surgery or stenting at our center. This was a retrospective analysis of 200 patients, 100 consecutive patients undergoing CABG, and another 100 consecutive patients coming in for stents. All patients were below the age of 50. We undertook this study in 2004, or we started this in 2004, to allow for 5 and 12-year follow-up. Patients who had had a previous stent or coronary artery bypass surgery were excluded from this analysis. The two groups of patients were compared for the primary endpoints of MACE, which is 1 or more of these complications: death from any cause, stroke, myocardial infarction, or repeat revascularization. The two groups of patients were quite well matched. You will see that the mean age of both groups is about 45 years. the majority of patients are male. There were more diabetic patients in the coronary artery bypass graft group, although this did not reach significance, 0.06. Hypertension, hyperlipidemia, lung disease, renal disease, smoking history were all similar between the two groups. However, patients undergoing coronary artery bypass surgery were more likely to have impaired left ventricular function and peripheral vascular disease. They were also more likely to have debilitating symptoms of angina. So the majority of patients undergoing CABG had class 3 or 4 symptoms, and the majority of people had very extensive coronary artery disease, 3-vessel disease or left main stem. Looking at the patients who underwent stenting, 74% had stents with a drug-eluting stent. 23% of patients had a bare metal stent only. The majority of these stents were placed in the proximal LAD and the right coronary arteries. The mean number of vessels stented was 1.2, and the mean number of stents used was 1.7 per procedure. Only 44% of patients undergoing PCI were completely revascularized. There were no strokes, and there was one in-hospital mortality. This was a patient with left main stem disease who had a dissection of the left main stem during stenting. The mean hospital stay was 2.4 days. Patients undergoing coronary artery bypass grafting, however, will normally have 3 or 4 bypasses. In our study, 92% of patients received a left internal mammary artery. 17% received bilateral mammary arteries. 86% of our procedures were done on cardiopulmonary bypass, and 14% were on a beating heart. This time, 90% of patients were completely revascularized. Again, there were no strokes and 1 hospital mortality. This was a lady who was admitted with a large myocardial infarction in pulmonary edema, had poor left ventricular function, and underwent emergency coronary artery bypass surgery for ongoing symptoms. The mean hospital stay was longer, as expected, at 6.6 days. At 5 years follow-up, which you will notice was complete, 100%, we find that the MACE was significantly higher in patients undergoing PCI versus CABG. This is the same for myocardial infarction, repeat revascularization, and hospital readmissions. There was no difference between the two groups with respect to stroke or mortality. When we stratified patients, depending on the extent of the coronary artery disease, 1, 2, or 3 vessel disease, we find that the incidence of MACE was again significantly higher in patients undergoing PCI versus CABG. Although the numbers are low, remember that there were more patients undergoing CABG in this group. This was primarily as a result of an increased rate of repeat revascularization in patients having 3-vessel disease and stents. At 12 years follow-up, which was slightly less at 95 and 98%, we find that the MACE again is higher in the PCI group compared to the CABG group, although it did not reach significance. As before, the rate of repeat revascularization and hospital readmission was significantly higher in the PCI group compared to the CABG group. And again, there was no difference between stroke and death. MACE was again significantly higher at 12 years in the PCI versus the CABG group. In patients undergoing stenting with 3-vessel disease. As before, this was primarily as a consequence of an increased rate of repeat revascularization, 66.7 versus 20.5%, but this time also because of a higher rate of myocardial infarction, 47.6 versus 19.2. So in summary, ladies and gentlemen, we have shown that MACE was lower in young patients undergoing CABG versus stenting at both 5 and 12 years. And this is primarily because patients with 3-vessel disease undergoing PCI have a higher rate of myocardial infarction and need for repeat revascularization. Thus, CABG should remain the preferred method of revascularization in young patients with 3-vessel disease. I thank you for your attention.
Thank you very much, Dr. Awad. You and your colleagues are to be commended for performing a valuable and informative study comparing less invasive catheter-based therapy with coronary bypass grafting in patients under the age of 50. The study shows clear-cut, long-term advantages with surgical therapy in patients with severe 3-vessel coronary artery disease. These advantages include fewer heart attacks, fewer other major adverse cardiac and cerebrovascular events, and a lower need for reintervention. The study is important for many reasons. The first is that it reestablishes coronary bypass grafting as the gold standard for the treatment of coronary artery disease in young patients. Similar advantages of coronary bypass grafting have been shown in other large and important demographic groups, such as patients with 3-vessel coronary disease who are diabetics. There's agreement here between both cardiologists and cardiac surgeons, and this is reflected in guidelines to which all of us adhere. The second is that it reminds patients, cardiologists, and cardiac surgeons of the importance of the big picture. We understand that these patients are young, active, and in the prime of their lives. It's only logical that catheter-based therapy, with its short hospital stay and rapid recovery time, seems to be more attractive and less disruptive to patients who don't want their lives changed by an operation. But it's crucial to remember that these young patients have their whole lives in front of them, and it's more important to make those lives longer and as event-free as possible. When I see young patients in my office who are in need of but are reluctant to have their lives disrupted by bypass surgery, I remind them that it's my job to see that they're working and enjoying their families next year and the year after that for a long time to come. I think that Dr. Awad's study reinforces the fact that coronary bypass grafting has a better chance of accomplishing those important goals than percutaneous interventions. Do you have questions for Dr. Awad? I want to welcome, I've heard a couple of things going on the phone. I want to welcome anybody who's joining us by telephone. Yes.
Hi, it's Lynn Peterson with Trends in Medicine. But when you did the comparison, you included revascularization, and considering that revascularization with the catheter approach is not necessarily a very big deal compared to revascularization by surgery, if you take that out and do the comparison, how do they compare? I mean, you have a higher stroke rate. It looked like.
No, the stroke rate was the same in both groups of patients. Patients who have this procedure have to appreciate that stenting is less invasive. But the interesting feature is that despite coronary artery bypass surgery being more invasive and offered to patients who are higher risk, we find that the outcomes are very similar in terms of mortality and stroke. If you take the less invasive element out of it, and you allow patients a period of 4 weeks to recover from their surgery, I think that you will find that the quality of life of patients undergoing coronary artery bypass surgery will be superior, because less patients will need reinterventions, readmissions to hospital with myocardial infarctions.
You know, I think your point brings up the dilemma, and you're right, catheter-based therapy is way easier. And the early results are similar. If you look at the results of myocardial infarction, stroke, et cetera, they tend to play out pretty even with bypass surgery. This is a big picture paper. You know, the big question is, what's the best thing long term? And when you offer it to young patients who want the quick and easy result, you have to point that out to them. And it's frustrating sometimes.
So I'm still a little puzzled. So if I look at the 12-year results, yes, there's a way high rate of revascularization. But if I look at stroke, there's a 0 stroke rate for a PCI versus 5% for CABG. But more are alive, which obviously is more important. But neither of those statistics, those comparisons were statistically significant. So if you take out revascularization, there's not a significant difference at 12 years.
Do you want to answer that?
First of all, our numbers are quite small. There's only 100 in each group. And you're absolutely right, the stroke was slightly higher in the CABG group, but I want you to appreciate that these patients had higher incidence of peripheral vascular disease at the outset, and they were higher risk patients. There were more diabetic patients. So I think that maybe a larger sample size would answer this particular question. But in our particular study, the significance was not achieved in respect of stroke.
And correct me if I'm wrong, Dr. Awad, but I thought that the differences played out even more dramatically when you separated out severe 3-vessel disease versus 1 and 2. Is that not true?
Yes.
Yeah. Other questions?
Ed Sussman with Doctor's Guide. Given the fact that most young people would prefer the quick and easy solution for immediate angina or even an MI, how long did it take you to recruit the patients to get the patients in both arms of this study?
We recruited them over a period of 1 year.
Other questions or questions to those joining us by phone?
I'm going to come back to this point, though. So basically, we need a larger study because you don't show any statistically significant difference in anything except revascularization. And if I asked that younger patient, do you want to have another surgery? Or do you really care? If you're going to go with PCI, maybe you're going to have 2 of them or 3 of them. But I think they would rather have 2 or 3 PCIs than a CABG. So you're not showing any statistical difference. I mean, the p-values just aren't there.
I think many patients would opt for this treatment, but I think that patients have the right to know about both options and to be involved in their treatment and to make up their own minds. I have many patients who are young and would prefer not to keep coming back to hospital for repeat interventions, which are not without risk. And the other thing is, we have shown that at 12 years there's a higher rate of myocardial infarction. Myocardial infarction results in impaired ventricle and heart failure. Now, although we did not look at this, but it will be quite interesting to see how many of those patients go on to develop heart failure and readmissions. And I would suspect it will be higher in the PCI group. And the reason I suspect it's higher is because these people are frequently under revascularized. So they're not fully revascularized.
Other questions? Okay.